or who's peeking at the live streaming and can verify that would be great. Okay. Just waiting for verification. And letting some other people in.
Jen, this is Stacy Danoff. We are live on YouTube.
Perfect. Thank you for confirming.
All right. Well, we are sitting a smidge over 1 o'clock. Before we get started, Jennifer, do you want to conduct a roll call?
Yes, I can. So I am Tom Delaney, Carol Backstrom, Natasha Mertz.
Sorry, Natasha's here.
Perfect. Brad.
Here.
Susan. Cindy St. George. Jessica. Here. Simon. Kathy Shavers. Jody. Here. Janelle. Mary. Randy. Sheila.
Here.
Josh.
Here.
Nicole. Laura.
Here.
At this point, there are 7 council members present. If I missed you, let me know.
And remind me, what is a quorum?
A quorum should be 10 members.
Okay.
So it's my
Well,
understanding that the council can continue, but not make a motion or vote until a quorum is present.
yeah, so kind of with that, and if you see anybody else trickle in, don't feel badly interrupting to acknowledge once we do hit quorum, because then we can go back and do some of these that I'm going to skip over here. So we'll start off by welcoming everybody to the June 2024 Acute Care Transitions Advisory Council meeting. We will call this meeting to order without a quorum, and if we have to go back and fix that, we can. And then if we can go on to the next slide, please. So just for a reminder for folks that the purpose of this council is to do a few different things set forth in statute. First one is to improve the regional capacity for acute care transitions, to create a measurement and evaluation system using implementation science. And then 3, to develop statewide strategies addressing geographic, racial, and ethnic disparities in addressing acute care transitions. In the next slide, you'll see our vision that we developed early on during our first meeting, I believe it was, where we shared ideas that led to the creation of the future vision for these acute care transitions. So again, these are just in here for reminders for folks and kind of to level set and ground us in why we are here. Next session, please, or next slide, please. So before we move on, just to remind everybody too of the public viewing opportunity today and in future meetings at Elmer Andersen Building in St. Paul, and as well as the fact that this is being live streamed for folks. If anybody is watching it on live stream right now, just remember that there's about a 20-second delay between the meeting and it actually getting posted out there on that stream. Comments can be submitted via email to the email listed there, and there will be an open session later on today, right around that 2:55 mark. Please continue to share comments. They're very welcomed and encouraged, and we're really hopeful that more folks will continue to share comments. All of these public comments will be sent directly to each of us council members. The staff and the team will analyze them for themes, and then all the comments will be considered when the council develops recommendations within the final report as well. Next slide, please. So this, well, we won't formally approve an agenda today or yet until we get a quorum. I just wanted to call out the fact that the original agenda and the one that's posted online right now is going to be changed slightly due to some scheduling conflicts. Some of the adjustments had to be made to today's meeting agenda. So an FYI that a meeting will be added in July to review the data from MDH, Minnesota Hospital Association, and the counties. And while decisions won't likely be made at that July meeting due to a potential lack of a quorum at that meeting, the meeting will proceed so that we can share and discuss the data from these various sources. Each of the sources have been asked to present their data, share stories, and then their top 5 recommendations based on the studies and the information that they have. So if for any council members that are unable to attend the July meeting, please watch that recording before the August meeting. So then on the next slide, we will have, this slide will have the adjusted agenda. So that's what we will be going through today. So we're going through that first section right now. We'll probably skip over the meeting minutes and then get into talking about the timeline and report activities for the actual draft of the report. And Rachel will kind of lead us through that exercise as we talk through that. Then we'll have an activity that will look at the focus group and the interview questions as we move into that kind of work. Then we'll have a break. Then we'll come back, we'll have an open session for public comments if there are any, and then we'll close out by getting back to the activity and getting back to the focus group and interview question discussion before we wrap up.
Dots, I'm going to interrupt you. I think we hit quorum.
Excellent.
Do you mind if I just call the names that I think that we have here? And if I didn't call your name, if you can just say yes when I call your name, and then if I missed you, then please tell me that I missed you. Natasha.
Natasha's here.
Brad.
Here.
Susan.
Here.
Jessica.
Here.
Jody.
Here.
Mary. I think she's connecting to audio. Sheila.
Here.
Josh, I know you're here. Nicole.
Here.
Laura.
Here.
And Mary, are you connected to audio now?
Yes, I am.
Okay, you've met quorum.
Excellent. Beautiful timing. It's like we did that on purpose. So I think the first action item, so confirm that we have a quorum. I'll officially call the meeting to order. And so now, based on the discussion, if there aren't any questions related to the adjusted agenda, I would look for a motion to approve the June 4th meeting agenda as amended.
I'll move the amended agenda.
And is there
This is Mary, I'll second.
Perfect. So we have a motion by Brad, a second by Mary. Any further discussion or questions? Hearing none, all those in favor, please say aye.
Aye.
Aye. Aye.
Any,
Aye.
any opposed? And the motion prevails. We have an agenda. Excellent. And then we can move on to the next slide, please. So the minutes were distributed for the council's review. Based on that review that folks did, are there any corrections or additions to the minutes from the April 30th meeting? And if there's not, I will take a motion to approve those minutes.
Sheila.
Sheila makes the motion. Is there a second? I will second it. So Sheila made the motion. I second the motion. Is there any further discussion? Hearing none. All those in favor of approving the minutes from the April 30th meeting, please say aye.
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 Those opposed, say nay. And the minutes are adopted. All right. Then we can move on to the next slide, and I will turn it over to Laura.
Hi, everybody. I'm Laura Arnold. I'm the other co-chair, and the next activity on our agenda is discussing the timeline for putting together our report and data gathering and organizing report activities. And I'm going to turn it over to Rachel Freeman to discuss this further.
Thanks, Laura. Well, okay, so we'll go to the next slide. So just as a reminder for those of you who were at the last meeting, we were having a discussion about the timeline for getting the report done. I did go back to some of the original documents, and I did want to ask a quick question to Natasha. Most of the language in the documents, the official documents that came out originally, refer to this as an action plan. So I'm wondering if we should be technically calling it an action plan report. Or, we've been kind of calling it recommendations. What do you think, Natasha?
Yeah, I mean, I think if the legislative language says action plan, that's the nomenclature we should use. And that's what, the legislature is expecting. And I think that probably was, an intentional language choice in the idea of looking, I think the legislature and our mandate is to produce a report that has, actions that can be taken versus just a report that might say, just study this more or collect more data, right? I think they're looking for what are the things we can do that we see from this work. Study and data are important. And I think will likely be part of our work going forward. But I think that action verb was very intentional in terms of what the legislature expects from this report. So it's a subtle and good question. Thanks for raising it.
Should we, language is important. And so it helps us to kind of lock in what we're calling this. So we might call it the ACTAC action plan report or action plan recommendations. I'm just a call out to all of you on what we should call this so that we're in line with the, legislative language.
Well, I mean, and this is Josh. At this point, thanks for bringing it up. I think it's something that we obviously incorporate. I don't know if we need to have a discussion about it at this point, just knowing that it's in the back of our mind. So as we draft this, we can certainly keep that in the back of our mind, I guess.
Okay, good. I bring it up because we'll be talking about it a lot now. It's rolling into the actual agenda, and we'll be kind of discussing it at each meeting. The timeline that you see on the screen here is a suggestion, and it's open for discussion. What we did is we started at the bottom of this table. So it says October 2nd at the bottom, and that is the due date for the end of the council process. There is some language, and I'm going to try to find it real quick. It says the Acute Care Transition Advisory Council expires on October 2nd or the day after the action plan required under subdivision 7, whichever is earlier. So I guess that means we could do it earlier if we wanted to. So that is going to be our backward plan. And so we need to think about, and these are the suggestions we made, how to get to the point where we have the final document. And the final document report, we would suggest somewhere in the week of September 22nd that it would be submitted to DHS. but we could also kind of do it a little bit later. So it's really open to the conversation here. We wanted to give some time in case there were unusual events or discussions that were going on. By September 11th, then there's a council meeting, and that would be when we would need to all be agreed on the final recommendations for that action plan. And it would all be reviewed and finalized. So that means by August, we would be reviewing a draft report. You would be getting the document. And so that kind of takes us into July, which is coming up fast. And that would be the council meeting that we were talking about with MDH and MHA presentations. And also we had some discussions that we'll talk about in a little bit about maybe breaking out into work groups. We just learned some information today that we'll talk about with respect to that. And then, but I'll hold on that because that's coming up in a little bit. But that means in July and August, that's when our focus group and interviews need to be completed and done. And so those of you who stayed on after we closed the meeting last time we met, was it April 30th? We actually had a conversation about a focus group. So the group of us talked about interview questions or focus group questions around a county focus group. And so in that meeting, we also talked about a number of other possible focus groups. So that's going to be a topic today, a little bit later. But that just means our timeline is by June. This is just a procedural thing, but there's something called an IRB, an Institutional Review Board. And since the University of Minnesota is involved, we would just need to get that through during this month and get everything up and rolling. So June 4th brings us to today. And so I want to just do a call out to Brad. Does this, I know you were one of the ones asking about a timeline. Does this seem logical to you?
I mean, I think it generally seems like it moves things along. I think I had put into the chat in the last meeting some signposts for getting some of those parts of the report drafted, and I'm sure you've got that down. So I mean, I think what I want to be able to see is the evolution of the draft as it kind of comes forward, and for us to all have time to kind of ponder it and deliberate over it.
Absolutely. And it's a really good encouragement for us to focus on. I think the key thing is making sure like what you're talking about is the writing of the action plan report, and this is the activities that go along with that, right?
Yeah, so what I'll do is just put into the chat the kind of little summary that I had done, because I know not everybody that's here today was at that meeting before.
That's helpful. And we do have that, Brad.
Right.
I can't remember what got put into the meeting minutes, but
It was in
might
the
be
minutes.
there. Well, yeah, I think I copied and pasted your thing from the chat directly into the meeting minutes because
Cool.
it was
Thank
very
you.
helpful. Yeah, we really appreciate it. So if this is our focus, it means that there's one piece of the puzzle that Brad, you had brought up, which is the writing of the report and how involved people are. So one of the suggestions that had come up in the last meeting was that we could have a breakout group that could work on the actual report and a breakout group that might work on the focus group interview process. We did find out some information about that. I don't know if Natasha, you want me to summarize what you sent in the email, or you want to just share it?
Yeah, I can share it. Just in terms of wanting to make sure that we're complying with open meeting law requirements. If we were to break into kind of working groups, though those subgroups or those work groups are also subject to open meeting law requirements. So we would need to think through how to do that. Like, for example, if we made working sessions here at Andersen and then had subgroups come in person, I think that could work. I think if we created breakout rooms and provided some type of way for the public to observe those breakout rooms, that could work, because I know we can't live stream like breakout rooms on our YouTube channel, or that's just feels really hard. So I think that's just the thing to know. I did confirm that it's totally fine for us to use like a Google Doc or some other type of a shared Google, Drive, if we want to post an outline, or for individual members could go in at any time and work and make edits in real time. So it's not so much the document itself or the draft or the outline that we need to be worried about in terms of open meeting law logistics, but it is if we create groups that are doing work on this report, we need to comply with open meeting laws for those subgroups.
And Jen, you had a suggestion. This was all hot off the press in the emails coming back and forth this morning. So Jen, you had a suggestion for the July meeting, right?
Rachel, I probably did, but I don't remember.
Okay. Well, I kind of remember it. You tell me if this is, if it tickles your memory banks. One of the things, Natasha, we talked about via email is the possibility of using the July meeting and actually having it broken into 2 groups. So do the breakout sort of thing that you talked about. So that is one suggestion. I don't know if it would work. We would just need to, I guess, stream both breakout rooms.
Yeah, I think something like that could work. We could also, in addition, definitely, book 2 rooms here at Andersen, and for people for whom showing up in person is easier or possible, we could have each room posted, each breakout room posted. So I think that could work.
So one other suggestion, and this is just we're all thinking outside the box at the moment. We have done really well working together as a large group. And so in the July meeting, we've got MDH and MHA presenting, but then we could use the time and have everybody work on those 2 sections together. So that way we wouldn't have to do additional work around the open meeting kind of strategies. So that's another option, I guess.
Rachel, I saw Laura's hand up and then Brad's hand up.
Hey, great. Thanks, guys. Laura, go ahead.
Hey, Rachel. Okay. I'm just wondering, and this is my personal preference, but I don't know what other people are thinking. It might be beneficial to have the physical space for this part of our work, being that the majority of it's been done virtually. So it might be nice to come together and to be able to create like a physical working document in that same space. And then we could live stream each room like you had suggested. I don't know what anybody else thinks about it.
Good, thanks, Brad.
So I just wanted to be clear, as far as I know, right now, we don't have any established subcommittees or work groups. Is that right?
That's correct.
It's just our larger group. Okay. And so just for people's edification, the open meeting law requires that if a quorum or a controlling group of a subcommittee or even a work group gets together, then that has to be a public meeting. So once you formalize that subcommittee, then that subcommittee is subject to open meeting law requirements. And then if you're going to get together the whole subcommittee, or you're going to get together a quorum of that subcommittee, then you've got to post and follow open meeting law rules. It does not prohibit, 1 or 2 of the members here, so long as you don't get to a quorum, of just having a conversation. Like, I'm sure Laura and Josh have had conversations about things. That's not an open meeting law violation. I've had conversations with Josh and Natasha. That's not an open meeting law violation. But I just wanted to make that clear for the people that are involved in this. And so I guess I'm open to having subcommittees, but I'm also mindful that that this group needs to keep moving forward and finding consensus about things and writing this report, which is due in a few months.
Natasha, does that correspond with what you, the information you got as well?
Yeah, it does. And I think Brad added some helpful context that it's about the creation of official subgroups, and that's very consistent with the information that I have as well.
So what we would be talking about is informal groups of people that might be looking at the document in between meetings.
Right. I mean, the other thing we could do, depending on how, what makes sense to this group is we can be individual people could be assigned or volunteer to look at certain sections or, identify and draft the sections. I think the way I'm thinking about bringing the report to the finish line here is we have, University of Minnesota on to help us make the report, pretty accessible, have the narrative flow, but the content, the actual recommendations, and what we want to say needs to come from this group and committee. So I think when we're talking about working on the report, from my perspective, we're talking about generating the content that fills the report, and then when we feel like we hand it off to the U of M, then to do the editing, kind of the proofreading, the wordsmithing, and then of course bring it back to make sure that what they've done makes sense to people, but that the role that we play is again generating the content, generating those actions, and giving guidance so that the U can then, create a full report with an action plan.
Good. Jen, I see you took down the slides. I know we're in conversation right now. I think the next slide is about an informal way of working through this. So if we went to the next slide, just to reiterate, oh no, you changed it. I'm sorry. Did I get the wrong one? There was a work group. Is that later in the activity? Somehow can you go back? Sorry.
Yeah, it's I think it's
Later on
in the slide, but I can move it around.
Why don't you just jump to that page? Because I think, it'd be good to just kind of finalize our decision on this before we go back. Thank you. That's what I was looking for. So we had this slide to kind of prompt us to make a decision about how to proceed with the report. I can tell you that we're going to go through the outline because that was in the meeting minutes that we would, come with something for you all to respond to. There's also about 20 pages written that is mainly the literature review. So, kind of the history or background and the information that we know from national and Minnesota-based reports, knowing that there's still information coming. So the question we have here is, do we want to just informally have a system to send the report to a few people, not as a formal group or anything like that, but as a way for people to respond to the content? Go ahead, Jessica. Brad, I think your hand has been up. Is it?
Oh, sorry.
I just want to make sure because I knew it was there, but okay, go ahead, Jessica.
I was in a different meeting earlier talking about file sharing across different systems. So maybe I'm thinking of that one. Is something like a Google Doc allowable where there can be multiple people inputting things at the same time? Or is more of a Word document email kind of the best system that we're able to use right now?
So this is Natasha. It's certainly possible for us to use like Google Doc or some or other, shared document that people can edit in real time, so long as we're not including obviously protected health information or identifying information at the person level, which I don't think we had plans to do anyway. So, that's typically easier than emails back and forth. And then when we feel like the draft is in good enough shape, right, then we can then create that link or find a way to share that with the public, which we can talk about the mechanism for that later when we get there. But yeah, short answer, Google Docs is fine. Some other type of file sharing is fine too.
So maybe in the chat, write down if you're interested in being in an informal kind of feedback process with regards to the report. And we will put you on the list, and Jessica will look at creating a Google page for this, but we'll also kind of attach it for those of us that aren't so great at technology or somehow can't get into it, because I know some of us are blocked. Go ahead, Brad.
You mean Josh?
Oh, sorry, Josh.
No, you're good.
I was looking at Brad's box and seeing a hand up over in yours. Sorry about that.
No, you're good. So no, I was just going to say too, I think as long as we're not communicating with the broader group too. So, if I'm sending an email, I should be sending it to you, Rachel, and or, staff, however we define staff. And we're not sending it to a quorum of other council members, or even, I shouldn't be having conversations with, a few on the side, then go have a few more conversations with a few others on the side. And then we kind of build up into that quorum kind of discussion and open meeting law violation. So, I mean, I think however we share the feedback, as long as we're not emailing the group as a whole and then we violate things that way, we should be okay. And I think however you all want to work that is how I always do it at the city council level or whatever. I email my administrator and we never email each other. And that's just the way it is. And then they share the information to the group, and that's how we work through that.
So you're suggesting that we get if you put it in the chat that you're interested, we would just email you as staff to take a look at this document informally.
Well, I guess I worry about the shared document, because if a quorum of us, if 10 of us are on that document at the same time, I could make the argument that we might be having a meeting and be typing things up if we're live sharing back and forth comments and we can see what each other's typing. So, even I know it's probably more a pain to do separate. I provide my feedback, then you have to put it into the document, and Brad sends his and Laura sends hers. But that seems, at least to me, a little bit cleaner, and albeit a little bit probably harder to manage. But then we don't violate anything, because I worry about, like, if we have this shared document behind the scenes, it's behind the scenes now, and now we don't have public access to it, and it feels different to me. But if I'm in the minority, I'm completely cool with it.
People who know
I-
me, Josh, would know that I actually prefer it that way, so it's easier. Sorry, did I interrupt somebody?
No, I think Josh is really hitting on an important point here, and that is kind of the university is kind of in the role of that administrator right now. And as long as people are communicating with you, you're just an administrator that's receiving feedback from the individual members, and that's fine. What shouldn't happen, unless we want to get into an open meeting law issue, we should avoid copying everybody or copying large groups of people on our comments. And so it's okay to pick up the phone and discuss with one or two other people, here's an idea I had, what do you think about it? But when you're actually putting the information in and communicating it back to the university of what you'd like to revise or edit in the working draft, it shouldn't be copied to the larger group. That way, the university becomes kind of the keeper of all the comments, and then all those comments can be attached to a future agenda so that everybody can see where everybody else is coming from, and that's completely public then, and that's fine. So I would kind of prefer it along those lines as well.
Okay, so we've got 3 people in chat who've volunteered. And so, one of the other things we could do is, if we know we're in a section that one of the council members would be really well suited to review a section or answer a question, we can certainly reach out to them as well. Great. All right, so thanks, Jody. Jody's added her interest. So I'm gonna have Jen take us back to the outline of the working document. So Brad, this changed a little bit from your outline. So but we have your organizer and your time, so we can look at that. Right now, this has been set up as the executive summary. That would be where a short intro and recommendations would sit. So it'd be summarizing everything, the main, recommendations we have for the action plan. But then the major first section would be an introduction and purpose with the history and background, and then legislative language and call for the actual action plan. What we have in this next section is the literature review. And in order to just get started, I went ahead and summarized by these different categories. And these are the ones that have been coming up either in the lit review, in our meetings, and in other conversations. So you've got your acute care barriers to transition, discharge delays, and acute, related to acute care emergency or hospital visits. You've got populations that experience more frequent barriers to transition. And then we move on to things like evidence-based strategies for effective transitions, the systems of care kind of issues that are clearly outlined in the discharge delay information. So when you read this literature, you'll see that there are the conversations about the need for beds, but there's also the conversation about the need for community supports and services and the need for better communication across systems. So that's a part of the summary of the literature that we're working on. The next piece is cultural responsive implementation science. So we all went through a summary of implementation science. One of the things that we believe really enhances the implementation process is by embedding that culturally responsive intervention into all of the pieces of implementation science. And then the last button isn't, or the last bullet isn't in there. It's a unified measurement system. So that is in the actual kind of first draft of the report. So this is a section that's already been drafted out for this little group to look at and respond to and communicate. And, we can talk about whether that's the right organization or something else needs to happen. It's really meant to just get the problem and the barriers listed out in a clear manner. So then once we do that intro and purpose and that information, we go to the second column. That's where our methods are. And so, the council meetings would be summarized. The literature review would be documented. The data sources are right now the state reports, and then the evaluation data that we have, interviews and focus groups. So that would be listed out in the methods, and it has been started, but it's kind of like pieces right now because we need to get the main kind of work done on that. Overview of findings. We have will be the results of what we find across triangulation. So when you talk about triangulation of major messages in different data sources, and we kind of go back to that evaluation question sort of issue. What we're doing is looking at the things that cross over multiple reports, multiple data sources across what people are saying across partners. You get a stronger message of how important it is. That doesn't mean that you might find a stray message that's important all by itself, because one person or a group of people might have that information that's really important, but that kind of triangulation will be described in the data sources and analysis as a multi-method evaluation kind of approach. All right, so then we move on to overview findings. And so that's just writing what we've found, and then the recommendations would be at the end. So I'm just opening this up for discussion. I think it would be helpful to look at Brad's outline as well to see if we've missed anything. I don't know if I've got it, Jen, if you want me to share my screen, or if you want to show the meeting minutes, we can just drop to the section that has the outline that Brad submitted.
I can do that. I also see that Josh's hand is raised.
Oh, I'm sorry, Josh, go ahead.
No, you're good. And so related to what you just said, I mean, that Brad copied and pasted it into the chat for everybody to see as well.
Oh, okay.
So that outline is in there, and it looks like everything pretty much correlates. Maybe there's one other one further down of other perspectives considered, or dissenting voices might have been the only piece that isn't somewhere outlined specifically in this outline, but I think it could probably be captured in.
Well, a question for Brad would be, what would be dissenting voices? Dissenting voices from the focus groups and the interviews about recommendations, or?
All I know is every task force or council or group I've been on, not everybody has agreed on every issue, and sometimes they've wanted their voice to be
Got it.
included, even though it might be a minority voice.
Thank you. Okay, well, that's a really important one to include. And then of course the appendix is also an important piece that'll be, you know, including the elements of the data. What
And
are
then-
the, when you have exhibits, what does that refer to?
Things like, let's say we talk about regions, in the thing, like a map. Let's say we talk about,
Yep.
or we want to highlight something in the history and we want to include a photograph.
Got it.
Something like that. Let's say we have, some data that, can best be portrayed in a chart or summary, and we can include a little bit of that in the text and body of the report. But sometimes it's just more information. We want to include it in the appendix.
If you're not on the group.
Sorry, was that somebody
Stream.
else?
No, I think it was just Matt Freeman talking too loudly when they weren't on mute.
Oh, okay,
Trying to channel my inner Hoffman here.
great. That's helpful. That is what I just don't call them exhibits, so that's helpful. Thank you. All right, so we will make sure those are added in, and then just to kind of refer to what we were talking about earlier, you see in the parentheses timelines for hitting some of the, you know, drafted out sections.
And Rachel, one other thing that I was going to comment on, you know, and it's not specifically called out, but I'm assuming it'll be baked in throughout. There was one, you know, under the review, and maybe even under the methods and findings, you know, I assume this is going to be Minnesota specific or Minnesota focused. Now there may be some, you know, nationwide best practices or things that whatever, but really making sure that this is, I think, focused on Minnesota and tailored to, you know, our specific situation. But then take it a step further to what Brad was alluding to with the regional side of things too. You know, are there unique differences on location across the state? Are there unique differences across gender of folks that are stuck, or cultural diversity, or, you know, all of those different populations, and just making sure that there's, if it's either called out somewhere or it's just kind of baked in throughout the review and the recommendations, because it might be different based on a solution here in, you know, southeastern metro, or, you know, up in the Arrowhead, or, you know, in southwest Minnesota. So just keeping that in mind.
Absolutely. And, you know, the degree or amount of information you want around the literature review is something in question. So you may not want all of these bulleted sections. What the smaller group might do is kind of review through that and respond. Well, it has been written such that, you know, there's definitely really important national information for Minnesota to know about. And if you don't know about it, you don't necessarily know that there might be some solutions available. At the same time, as you pointed out, Brad, this is a Minnesota report. So it's kind of like getting the balance right and considering how to proceed with the major summary of the barriers. The big message I have walked away with personally from the literature review is that this has been a challenge from before the pandemic. And in fact, 1990 is around the time where you see most of the systematic review data showing up. But there was one systematic review that actually included 1946 because there were some earlier kind of indicators of studies related to delayed discharge kind of information. Clearly, the pandemic has escalated the challenges, but there's also a very big message that this is a worldwide issue that many countries are dealing with. Now, the way in which we deal with them are vastly different. And as you mentioned, Josh, we've got to be careful to make sure that the information is relevant strictly for Minnesota. So that's going to be, I think, our first step is to look at the intro and purpose and see whether the way it's flowing right now works, whether we want to review and kind of adjust. And we'll be working on council methods. That's actually started, but needs to kind of be fleshed out a little bit more. All right, I see somehow, oh, no, I guess Josh is still first in my boxes. But nobody's got their hand up, so that's a good sign. One thing that we could do is go back to the timeline and, now that we've got the intro and purpose, we could have a target for presenting at the next meeting, something that's more than just a draft. And that would be, what would that be, Jen? That would be July, right?
Yes, to be determined. That is something that it sounds like the council is interested in having that meeting in July. So if I can follow up after this meeting with sending out a doodle and scheduling a date that works for most of the council.
Okay. Great. All right. So if you can just go back to the outline. I think we just need to put dates by the rest of these sections in the way that Brad has outlined. And so let me see, background and history was July. So we're in good shape for that one. Summary of meetings ongoing. We could have that one in draft form probably by July. The findings, I guess the methods I would add to that. That needs to be done in June, because that'll be part of the University of Minnesota IRB. And then I think the other dates that you have, Brad, we could just plug those in, right? The one thing we'll want to do as we proceed is really make sure, and this is something I want to maybe throw this to Laura. Laura, you had a question about, starting to map out recommendations, even though we don't have all the data yet. That is something that we could be starting to outline as a way to kind of see, as we gather data, are we actually getting evidence of those recommendations being accurate? So thoughts on that to the group?
I think it would be reasonable because the majority of us have identified some potential common themes. And so it would be nice to use that as an organizational framework for processing the data as well.
Oh, I see Jessica's got her hand up.
Yeah, I would agree with Laura. And as I was looking at Brad's outline again, and then at the outline you have here, Rachel, some of these sections I think are going to take more time and thought, the summary of the meetings that can be summarized pretty easily, right? But probably the most important action pieces to this is the action planning. And so trying to get that moving on the earlier end so that we have a lot of time that can be kind of allocated to that section seems to make a lot of sense to me.
Well, one thing we could do today is squeeze in some time to just map out recommendations that we have. I think we've got plenty of time to do that, and that would get us started in the way that Laura is talking about. So that would work. That would work great. Do you want to, let's see, can I see what's after that work group, Jen? Let's see if I think we could do that now if we wanted to start working on recommendations. And I know, Laura, you had mentioned one in one of our sort of breakout meetings. Just for an organizer, Jen, do you think we could create a slide that you could just sort of take notes as people are talking, as a way to kind of capture recommendations?
Yeah, I should be able to do that.
Okay. So Laura, did you want to share the one that you were talking about in the last meeting?
Well, I need a refresher because I have quite a few suggestions.
You sound like Jen. Well, you could just come up with new ones too.
Well, two off the top of my head would be better pay for those direct care staff agencies, the reimbursement, so that they can provide those services. And then the other one is, and I think it's something that we've all identified in different maybe wording or ways, is creating a central database that is managed by like a specific like role, so that the various community regional people that are trying to do case management and things like that can actually find resources that are available in real time and efficiently.
Any other recommendations that people are wanting to make sure we consider? I think Josh, you were first. Go ahead.
Yeah, no, and I don't mean to derail from this conversation. I think one thing that I'm going to be thinking about throughout this process, and I'm not sure if others will be as well, is, you know, as we're thinking about recommendations, you know, how do we capture what's it going to cost, and or what is the lift? Because I think while that shouldn't be the driving force behind recommendations or a barrier, perhaps, you know, that we fully consider or weigh in, it's something we need to think about, because I've seen a lot of task forces and a lot of recommendations and a lot of reports come out and wish for and want a whole bunch of things and know a whole bunch of things need to happen. But knowing that so much of this work is going to be done by our state agencies and partners and counties and others, resources have to be tied to it. And so while there may be recommendations for increases to whatever it might be, that comes with a price tag and may or may not be feasible, doable, or even realistic in the near term. So I guess my question to the group is, what do we want this report to be? Do we want it to be here's what we think needs to happen regardless of the price tag, regardless of the lift, for things to actually happen and have an impact? Or is it, or maybe it's you know, here's all the things that need to happen, and then we label them as, you know, costing X amount or whatever, and then we can prioritize or at least provide recommendations. You know, if we get $1 billion to spend next session, this is what we want to start to target. If we get $10 million or $50 million like last session, here's what we got to cut it down to, and here's some of those recommendations that may or may not have fiscal costs tied to them, but are still going to be impactful short, medium, and long term. So just trying to think through how we come up with these recommendations so that we don't go back to the report.
Yeah, before we go too much further, I think if Jen, you could also copy the 3 bullets that are the charges of the action plan itself. That would be helpful for us to make sure that we're anchoring in the way that Josh, you're talking about, but also by the charges that are 3, the ones that Josh went through at the beginning. A little bit higher up, it's after the picture. There you go. And then go ahead, Brad.
So I threw just one in there, which is actually like bullet number 1, which is improving regional capacity for acute care transitions. And I think recommendation number 1 is to make it real clear to the legislature and to the state, state government that this group prefers a regional approach over a statewide approach. Then the question becomes, what's the vision, right? So what does it look like? And to Josh's point, there may be some things that we look at as practical recommendations, because we know that having a long-term vision gets really expensive and things evolve, but there are some things that are affordable or conceivable or practical that we can get done within a short period of time. And then what's the aspirational vision? Like, if we had all the time, if we had a couple of decades to improve everything, where would we want to end up with things? And I found it really helpful to sit down with Natasha earlier this year to kind of talk through some of the things that they've been working on and the regional approach and things. But I think there's even some more potential in the future as we get to talking about this. I think one thing that might be helpful is for everybody that's a council member here to do some of their brainstorming in between meetings rather than in meetings, and to put it down on paper, to write it up, and to send it in. And I'm wondering if we would want to send it in to, and then that can be shared as a part of an agenda. But if we want to send it in to you, Rachel, or somebody that can then include it so that when the agenda comes out, we can see what other people's ideas are and have a little bit of time to process that before we're just reacting to it or trying to compete with ideas some of which we may all share. So those are just a couple of suggestions that I have.
Those are great. Thank you. Natasha. You have to get off of mute somehow.
Yeah. Looks like you're still muted, Natasha.
Matt was talking too much, apparently.
Yeah.
3 minutes.
That's okay. So we've got Jen getting the three, major charges of the action plan, and the two of the bullets you have below are actually those three. So the only one missing is the cultural responsive sort of planning tools. So that'll be good. Well, Natasha, you jump in when you can. We'll go to Laura next. Brad, your hand is up. Were you done? Oh, you got something else to say? No, you're done. Okay. Go ahead, Laura.
The other thing that I had mentioned before too is maybe writing a recommendation that encourages entities to do those assessments that are needed for gatekeeping proactively. Because there's quite a few people in this population that when they're coming in your door, they're going to need extra supports. And unfortunately, if you're not doing those assessments in a timely way, then that creates multiple delays in access and then extra waitlist time.
Thanks, Laura. I wanted to go back to something that Brad, you said about regional, what'd you call it? Creating a regional approach to acute care and transitions. You had mentioned in earlier meetings several times that is something that we could do for the report and use it as an exhibit. But the regional mapping issue that you brought up is something that I think we should have in the report as a way to summarize all of the things happening at a regional level, kind of going back to Josh's point of we need to leverage existing resources rather than, trying to spend money we don't have. So if we can look at what are the existing regional maps, regional resources, and other types of things that help to maybe from a systems of care kind of point of view, coordinate better, that could be something that would go into the recommendations. Am I getting that right, Brad? It's something that you've mentioned a few times.
Yeah, I think partly. I mean, the whole goal behind some of this, I think, is to keep and transition individuals who need acute care in closer proximity to their homes, whatever that means, or their families or supports that, where they want to be. And I know that, and Natasha, please correct me if I'm wrong on some of this, that the state had gotten some kind of funding or support and started to conceive of kind of 3 general regions in the state that are kind of, northern Minnesota, southern Minnesota, and central Minnesota kind of regions. But those are very big regions, right? And that may be practically what we can do now, but then would it be better if we had the resources and things available to us after we identify what are the resources in those areas to even have smaller regions? And I've floated the idea out there, and I'm not trying to drive this, but I do think there are some advantages to it of looking at the 10 judicial districts, because whenever you have people trying to pull together multi-disciplines and get counties to work together and get systems to work together, those districts, generally speaking, have already been working together. And so I've started to talk to some people so that I better understand the issue at the county level on what that might look like. And I've got some ideas that I want to share along those lines, but candidly, they probably, you know, part of a vision, right? So it probably can't be something that I just throw out onto the table in one of these meetings and have everybody go, what do you think? You know, so I think that maybe we all need to have a little bit of an assignment that if you want to weigh into the vision part of this report, that you should kind of put it down in writing and circulate it to the authors of the report and include it for distribution with the agenda that goes out so we can see what other people are thinking. There's just not enough time to do it all in a meeting like this.
Well, and I think that point is something that we want to have in the action plan, which is there are things that need to be done that you can't do in this timeline. So here's the action plan recommendation, and it includes what you've articulated. So I think that's a really good way to proceed.
But you also mentioned like resources, you know, like a map of where the current placements are, a map of where the major hospital systems are. In the state. It just helps us all visualize the gaps in whatever we're trying to put together.
Yep. Thanks. Okay, Carol, I see you've also got some things in the chat as well.
Yes, and of course it took me 15 minutes to figure out how to put my hand up. Challenged. So I asked a question around sort of, I'm sorry, I'm coming in late to the meeting, and, you know, also I wasn't at MDH at the time during COVID, but didn't we have, and of course I'll do my homework internally, didn't we have a real-time hospital bed sort of availability system for, I mean, I get that it was for COVID purposes and it was really focused on ICU availability, if I'm not mistaken, but I would also say that when I was at DHS, you know, albeit 11 years ago, we also had some kind of system, I thought, specifically for ANOCA, for example, or like other bed availability. And I'm not sure if that is still in existence and is still utilized. But my main point in bringing up both of these is the possibility of building off of existing systems. So I'm sorry if you have all talked about this at some point. Thank you.
No, it's perfect, Carol. It's a really good example of looking at what we have been doing in the past, how we could think outside of the box and use a measurement system that would really help us get better at supporting people. So I think that makes a lot of sense. And Natasha has jumped in saying they are having audio problems, as you expect. But that she's saying Brad's exactly right. We are using federal money follows the person to fund staff to work in these 3 big regions, but I'm hoping the council can recommend the right regional approach, judicial districts, et cetera. And what she wanted to say before is that when we talk about increased rates to pay staff, that is super important, but also I wonder what other types of support DSPs need to work effectively with people with complex needs. Something that was mentioned earlier, I can't remember which one of you, but you know, about training and positive support, self-care strategies, strategies for supervisors to provide good support, all of those kind of things. I want to circle back to the regional kind of comment that Natasha is making, because I feel like we've gotten some momentum on that particular section. And I like what Brad, you're saying, which is if people could zero in on some of these bigger themes and write down what you believe we really need to be considering, I think it'll help the report tremendously. And it'll also help us get the report written. So if we're looking for money follows the person maps, judicial maps, cohort, like in my experience with just training and positive supports, we have these really interesting little subgroups within regions because regional teams tend to be self-organizing systems. So it's a real interesting kind of question that I think is going to be really important for us to look at. With that, I'm going to bring it back to Laura.
So to kind of piggyback off of what Carol just said, as far as, you know, the real-time bed availability, I know that there's some system in place still because I see it through my work, but also I don't know if it's there for like our transitional care providers, like our outside community providers that for our patients that need beds. in those settings. And so it would be good to, like in that creating a database section that I suggested, like that was something that would go with that so that we know what's even available in our regional areas to place people in, but in real time, and then that capacity to serve.
That's helpful, Laura. As you're talking, I'm thinking about how these fall under the 3 bullets. So I'm like moving stuff around in my head, and I know Jen's struggling to keep up with all of us. So I appreciate you, Jen. So I think Jessica, you're next, and then Josh.
Yeah, I 1000% agree with the regional need, and I know that's also a number one, thing that we're tasked with doing. I also wonder about recommendations for things available kind of border to border, from the sense that a lot of people might be moving across regions when they're transitioning back home, or there might be certain things that are not available in certain regions, and there's a lot of kind of coordination that has to happen. Or again, along the points, it sounds like some groups do a lot of that coordination well already, but that should be a consideration in addition to equipping the regions and taking unique approaches with the regions that I totally support, that there needs to be some of these things that are available throughout the state, knowing that people are going to be in different regions, maybe accessing specialty care and then needing to kind of move back home, whatever that means to people.
Thanks, Jessica. Josh.
Yeah, no, I mean, I love the regional discussion. I think this is where getting the data and the information, whether it's from the counties or DHS or hospital association and stuff too, where we can actually see some of that, because that's going to help with, I think, some of the recommendations. So one of my questions was, and maybe I missed it, but could we get that, the first, whatever you said, however many pages of the lit review sent out? Because that might start, jarring some ideas and some thoughts, and also based on this discussion. But I think, as we come up with these ideas, Brad said it, we've all said it, so I think homework obviously for the group moving forward is to start sending this in to you, Rachel, and or Jen or whoever, so that we can start aggregating it all and then bringing it back to the larger group. I want to make a comment, and I know this isn't what Natasha was saying, but I wouldn't do my job as an ARM member and board member if I didn't say, just training and everything is fantastic. And I think we just got to keep in mind that any additional training or whatever, making sure that it's not unfunded mandates or requirements that are, locked onto providers that are already stretched. And if additional new training is appropriate and necessary, are there other administrative / other things that could be replaced with this newer training, so we're not just adding on to an already burdened system of providers with no capacity to do anything and no reimbursement on top of that. So, and I know that's not what Natasha was alluding to, but that's one of the first things that comes to my brain when I hear additional training. And, other agencies are notorious for adding on more regulations and things like this, and then no additional funding to offset that, and providers just have to deal with it. So.
It's a really good point, Josh. And I think one of the things we're learning is that, leveraging includes figuring out how to put the training into the systems already in place that are expected to be able to get access to reimbursement funds and things like that. So rather than adding, we're actually streamlining, integrating, leveraging the things that are already in the state system so that it makes it easier for people to get access to funding. So the example being like a positive support service reimbursement system, if it was easier to get qualified to be able to access the funds, then people are going to use that. So improving the systems is kind of what you're speaking to. All right. Well, Natasha, whenever you guys get fixed out there, you just let us know and jump in, okay? So far, we have talked about 2 out of 3 bullets, which is, I want to make sure we've done a lot about talking about the regional kind of capacity building, but we also talked about measurement, and Carol brought in the idea of looking at existing measurement systems and really figuring out how do we do a better job of a unified way to see what's going on and how to support people to get back into the community settings. The one section we haven't talked about is how the strategies for addressing geographic, racial, and ethnic disparities. In some ways, I think the regional approach touches on the geographic part of things, but I want to open this up for some discussion about, what kind of recommendations we have for improving our possible disparities. Carol, does MDH do any kind of data around like healthcare disparities or things like that?
We do, not as good as we should, of course. But as you may know, it's a really high priority for our commissioner. And so we are doing more and more around disaggregation of our data sets to see how we can be, or what the gaps are for starters, and then trying to build on that in the coming year and legislative session, in fact.
Thanks. I know there's 2 Minnesota reports. One is from the Minnesota Governor DD Council. One is from, I think, the Medicaid director. Is that right, Jessica? Those 2 reports are available for this particular issue, which is a good thing to those are public available linked reports that we can send to you all to take a look at. I think the more we can consider what, using people like Carol and your advice on how to proceed with this, just like Brad said, we can't solve everything right away, but maybe there's ways to kind of build on some of the efforts that have started anyway. Laura, go ahead.
To add to the encourage proactive assessment, I don't know if you saw in the chat, but if we could look at improving data sharing to reduce redundancy, especially between like county agencies and things like that.
Thanks. That's great. I mean, I know one of the things that Danny, you've talked about is creating ways in which we have more conversations, relationship building, listening sessions, ways to really understand better how we can improve our services. Do you have any thoughts about what kind of information we might want to investigate?
We're looking at the disparities.
Yeah.
I think it's kind of complicated when you're looking at the disparities because you're looking at some underrepresented people who don't always speak out just because they've been asked numerous times to come to the table, been saying the same things over and over again, and things aren't changing. So it's really hard to engage that. But in this kind of a setting, I think that, reaching out to those people and coming to them is probably the best way to do those kind of things rather than having them come to us, letting them know that there will be a report, that their voices will be heard, that, people in decision-making authorities will be hearing those kind of things, I think can go a long way too, in making sure that, we do get some really quality conversations going. So, those are my initial recommendations when it comes to those kind of things, but I think we do need to reach out to them and actually go to them.
I think about that, and I think about, Carol, what you were saying, which is, there are things that we could be moving towards. And I wonder if having some sort of recommendation where we're actively working on making changes in the way that you all have talked about, which is to improve the systems, be more responsive so that, like you said, Danny, people can see changes actually occurring as a result of sharing information, that kind of thing.
And just to build on that, like I don't know if timing would work out, but if there are legislative proposals around, for example, collecting disaggregated data or collecting data in a different way to this end, that this group could, reinforce, that would be, for all the same reasons, all the good, rowing in the same direction is all I'm trying to say.
Mm-hmm. Mm-hmm. I think the other thing that we've mentioned earlier is that, that implementation science and how if we integrate into each of the pieces of the technical assistance and supports for people, things like adapting evidence-based practices so they're more culturally competent, so they're more responsive to people's needs, that having that built into what we're recommending is something that I was seeing in the literature. So I thought I'd mention it. Josh.
Hey, Rachel. Yeah, this is Josh. So two things. One, I swear I thought that Center for Health Equity changed their name within the department. So whatever their new name is and whatever they're doing now, I mean, that group within the Department of Health would probably be somebody worthwhile tapping for some insight into this. But then also, I was talking to a couple of my students for the U of M course that I teach for senior care management and assisted living. And most of the students that go through that course are English as a second language, BIPOC, from a culturally diverse community, and they're running into barriers left and right on the post-acute side of things. So I'm talking, sorry, my dog. I'm talking assisted living, home care, those types of settings, and they're struggling just, understanding and getting into the regulatory structure that is overly complex for most of us anyway. And so if there's a way to, I'll reach out to our PAM folks, but I think of them right away to offer their insight into some of the barriers and the issues that they're facing to be able to serve folks, whether it's a licensing thing, an interpretation of regulations thing, or whatever, and how they can have a voice in this as well.
I would say this is one of the key areas that we might put towards the focus group interview sort of process. So we have a certain number of interviews, about 10 that we can kind of zero in. And I'm thinking, Carol, if we could get recommendations from MDH of group people that you think might help us to kind of craft recommendations around this area. And then Josh, your point, and thinking about things like RPM Minnesota, like groups that represent different, partners that can help us think through this issue in a different way. Okay. Yeah, this has been good. I think what we can do is take this and kind of get it started within the report around recommendations, and then look at what data we need to be collecting to kind of make sure we understand and can back up some of these recommendations. Like as an example, what this taught me is that from the lit review point of view, we need to have a regional section that kind of looks at what are best practice around regional interventions, what's happening in Minnesota around those regional maps that we've been talking about, so that those are available in the appendix, and maybe as a way to do an overlay of the different types of resources that are at the regional level. So that should help us move forward with the report. All right, let me see if there's anything going on in the chat here. Health Equity Division, and that is in MDH, Josh?
Yeah, it was the Center for Health Equity, but it changed its name.
Yeah, there was an announcement that just recently went out that our Center for Health Equity within our Health Equity Bureau is now a division, and it's really kind of just a recognition that it's expanding, its scope is expanding, and I'll stop there. It's a big deal for us internally.
It sounds like a big deal, and it sounds like it has a lot of implications that we should be thinking about. Is that right?
I think that, your suggestion, Rachel, about sort of tapping into their work would be good. And I have to do a little thinking about how best to do that. And I can talk to Dr. Tura, our Assistant Commissioner of the Health Equity Bureau, and see if he has some ideas. If Rachel, if you could sort of make sure that I can sort of describe what the ask might be in terms of whether it's community engagement and around what, we might have some infrastructure help on that, but.
Okay, so what you want me to do, Carol, is write kind of a paragraph that outlines what we're asking about and what our charge is, kind of like this is what the Acute Care Council is doing. This is what we're kind of exploring at this point around recommendations, something like that to get.
If you wouldn't mind, I'd really appreciate it. Yes.
Absolutely. Jen, can you make sure that's an action that we've got somewhere? I know you're doing 300 things, so I appreciate you. All All right. Let me just say before you jump in, Laura, Natasha jumped in and said one strategy could be to get recommendations from the council for different groups, organizations for the focus groups. Yeah, that is actually the later activity, Natasha. So I've been thinking about this because we have an activity later, which is actually to get recommendations for interviews and things like that. And I feel like we're zeroing in on that. Like if Carol, you can be thinking about people that might be good for us to, pick their brains or something like that. And same for you, Josh. You had some ideas about people we might want to talk to. That's a really good idea. Okay, Laura.
That's actually what I was just going to say because I have two big things in my mind. So I will go with that.
Sorry.
That's okay.
So, to that point then, to the council and Rachel, I'm just looking at the agenda. I didn't make a minute marker announcement at 2:10. That's when we were anticipating to stop with the outline of the report and report. However, I think there's some, I'm sorry if I made a judgment, but I think there's a little bit of flexibility here. But we can, if you want to transition, if you want to wrap this up and then transition to the activity focus group.
I mean, we've got about
that would be in alignment with the agenda and then take that until 2:45.
Yeah,
And
that's great, Jen. I was looking at the old agenda, so
yeah. No, that's, and then I think that would, if others are looking at here, you know what I can do is I can put the agenda up here.
Could you do that? That'd be great. Because I was looking at the one from the email we sent everybody.
If it works to do that until 2:45, and then knowing that you all will likely not finalize that conversation until after the open session, and then go back to additional planning for focus groups and interviews.
That sounds great. Let's go ahead and let's wrap up. Is there anything else we want to add to this section or have actions related to it before we move from recommendations? I think we got a lot to get started with that we can reorganize and have you respond to, and hopefully kind of move us forward with this section.
And I just want to reiterate the actions that I have in the notes, and that is one, that was what Brad suggested for the council is that, and I think Josh, the sharing of the lit review, and that council members continue to brainstorm recommendations and they can share those with the ICI staff.
Okay, so just one question. It takes us back to the open meeting thing. If I send the lit review, do I disconnect it from the action plan and just send it as a document? I'm just trying to think about what we talked about earlier, making an informal attachment based, a couple people, but not the whole meeting kind of approach.
I'm sorry, I didn't understand the question. So if you did what, then what?
So, okay, so the action is that we send out the lit review to everybody.
Yeah, that's just distributing materials.
So that is not a public domain sort of issue. Do we need to make it available to everybody if we send it to everybody?
Rachel, my understanding from the conversation was that sharing the lit review to the council is disseminating documents. Where it goes into the kind of open forum is that if all the council members are in the document or many council members are in the document at the same time.
Oh, so just when they're working together in the document? I'm sorry, I must have misunderstood.
So the document would become public when you share it, because you're sharing it with a public body and you're sharing it with all the members of the public body. Although frankly, it might be helpful if Natasha got some input on that, whether it's, from the Attorney General or something like that, whether draft documents are subject to that. But it doesn't trigger an open meeting law violation for you to share materials.
Okay.
What triggers an open meeting law violation is if people start conferring about that document and things like that. It's really no different than city council getting, a copy of an agenda in advance. That agenda is public. but
Okay.
that's not an open meeting law violation, generally speaking.
No, I was just wondering if it was it became a public document that needed to be shared with the public, so.
Is there a reason not to post it and just put it as a draft of the lit review?
Yeah, working draft.
Right. Assuming that it's not finalized and we label it as such and it's drafted and stamped everywhere that says that, it certainly could be posted to the website too, and folks could offer input on that draft if they really felt compelled to provide public comment on, the draft lit review. I mean, there'd be no reason to not share it.
I feel bad asking Natasha this when she can't talk. I'm wondering how they handled it in the priority admissions task force, because they had a similar dynamic there.
That might take a while to write in chat. All right, well, Natasha will report back out on that, I'm sure.
Sure.
And that is a really good question. So thank you for my slowness in figuring this out. And I will certainly send out the lit review. Just know it kind of gets a little looser at the end of it. So, but it hangs together. So, all right. Jen, I interrupted your action planning. Is there anything else you want to ask?
I just want to summarize actions that Natasha will determine if sharing the draft of the literature needs to be shared with the public. It sounds like that is the case. ISCI will share that working draft. And I have an action here that you will write a short summary of the purpose of the council and to ask for those that we are approaching. And I feel like that might continue to be an action item into the focus group question as well.
Yep.
Is there anything I'm missing? Okay.
All right, so we'll go to the next slide, I guess.
I'm just gonna save real quick.
Yeah, take your time.
And then go to the next few slides.
See where my notes are here. Moving everything around as I was taking notes. All right, so we are we're moving to the focus group issue, Jen. So as a background, somebody is talking to me on text saying we need a break. Do you guys want a break now? We're supposed to break in about 20 minutes or 15 minutes.
15 minutes.
Do you want to take a break now or you want to keep slugging forward? Some people are wanting a break now, so I'm going to vote.
Let's take a break. Let's take a break and then we can come back.
I'll back up Natasha on that. So
Yep. Okay. Me too. I vote break. All right. So we'll take a 10-minute break, everybody. Is that right? What we've got here?
Yes, it's a 10-minute break is on
the 10-minute break. Off you go. Have a nice break.
So Natasha, I'm here if you wanted to test audio.
Can you hear us now?
Yes, we can.
Yay! We can hear
What'd
you.
you do to me?
Well, just hitting one brought up the options.
Yeah.
And then once you're in the options, you hit whatever. So I hit two.
Oh, to unmute. Okay, so it's one and then two.
Yeah,
Okay.
and then exit menu. I just know how to get rid of that. There we go.
Okay. Sweet. Thank you, sir.
Yeah.
Well, that's got to be uniquely challenging, Natasha, to just listen to it all.
Well, I mean, it is, but in some ways, you know me, I'm not very shy about sharing my input. So it does force me to listen, which is actually probably better overall.
Well, I appreciate the stuff you added into chat.
I'm gonna run to the loo, but let's do right before we open, let's quick do another one. I'm gonna go on mute in the room and hope that that works. I think I know what to do if it happens again, though.
Sounds good.
All right, we're a bit overdue from our 10-minute break, but if everybody is ready, we'll get restarted again. And I'll kick it back to you, Rachel, to jump into the activity.
Okay, so we only have about a few minutes before we're supposed to be heading towards open session. So maybe we do an organizer. Jen, is that your thought? I don't know if you're there, Jen.
For the report, I'm sorry, I was getting my mouse situated for the report or the next session, Rachel.
So we have open session at 2:55 and so it's now 2:45. So we just have a few minutes. Maybe we set the activity up and then go to open session and finish afterwards.
If that works for the council, that I can make that work on my end.
Cool, let's do it. All right, so this is the other major activity. And just as a info for those of you who didn't stay, last meeting, we ended a little early. Things went faster than usual, but there was a group of us that stayed on after the close of the council. During that time period, there was about, I don't know how many, 6, 7 of us. We were looking at the focus group and interview issues. And so we talked about what kind of things we'd want to do for focus groups. We had originally kind of had funding for about 4, but it seems like 5 focus groups are kind of targeted. And you can see that on the screen. We first started talking about a county focus group, providers, tribal nations, hospitals, and then families and people with lived experience. So that was the idea for the focus group. The interviews are meant to kind of catch maybe individuals, as we talked about earlier, that we might want to get information from that we otherwise wouldn't or wouldn't be a good fit for a focus group. Any thoughts on these groups? Are there any groups that you're thinking that we might be missing as far as partners?
Can I ask why we're doing that?
Yeah, the legislative ask was to have the community provide feedback on what the recommendations are. So the purpose is to gather people's perceptions, viewpoints, concerns, barriers around the acute care, barriers to transition. It's a really good question, Brad. Right now, what we've got is reports, state reports that are looking at discharge data. What we don't have is the community perceptions and the community sort of recommendations yet.
So the idea would be to have a meeting, invite, I don't know, all the county public health people to a giant meeting, or what? Or are you talking about just the people that are part of this? Are you looking at the focus groups as being like a subcommittee or a subset of this group, or are you looking at them being the public at large? Not a member.
It's part of an assessment. It's not part of the council. It's the information that's being gathered from the community to be brought back to the council for review.
Gotcha. Okay. Thanks.
Thank you for clarifying. And we don't have all the methods mapped out, but the idea would be to send out an invitation for people who want to participate, and those who send in that request would then be, added to the invite list. But we should circle back to that. But let me have Laura, did you want to say something real quick?
Yeah, I was just wondering too, and maybe this is something that Brad can speak to, but shouldn't we have something that represents like our Department of Corrections cohort, like people that are transitioning from that setting to community services and things?
Yeah, I mean, one of the transitions that's a difficult transition in every community is that transition from jail to hospital, or hospital to jail, or prison to community-based kind of thing in somebody's home community. And so I'm not sure whether the focus group ought to be people with lived experience that have been incarcerated, or if it needs to be, you know, sheriffs and Department of Corrections kind of people, which I'm thinking it's the latter because they have essentially the responsibility for the care of those people while they're with them.
Yeah, I think it should consist of anyone that's involved in supporting that transition. And I don't know if social work also facilitates that. I'm not familiar with that population, but I think that should be included in that focus group.
I suppose that could be part of the county outreach. But it wouldn't, I mean, I guess there's another component to it too, and that is that excludes the state Department of Corrections.
Hey, this is Natasha. Can you hear me?
Yeah.
Yeah. Just winning. Just on the Department of Corrections piece, coincidentally, the complex transitions team who are listening into this meeting, we have had some initial conversations with the Department of Corrections about this population of folks transitioning out of being justice involved and into community, and some of the barriers that the people in DOC that help and work on transitions are finding in terms of getting folks out. And so at a minimum, we can easily make those connections for a focus group. Might need help from others on kind of the sheriff or the county focus, but we can definitely make that connection happen. And I think that gives us a good place to start, maybe.
Thank you. Perfect.
Josh, you had your hand up?
Oh, that was Natasha just now, Danny. She has 2 boxes.
Oh,
Sorry, no,
I think Josh has his hands
had
up
my
too.
hand up and then I started talking and I forgot I was on mute.
Oh, Josh is just talking to himself.
I know, I do it all the time. But you know, under the provider side of things, you know, obviously ARM, RPAM, the imperative, you know, those types of groups can obviously bring together a voice that represents a whole bunch of others, Minnesota Home Care Association. So those on the post-acute side of things. Laura and or Brad, I mean, I think the contracted case management folks for sure, and then those contracted case managers, so Tiffany and Randy here can probably speak to some of those entities of you know who the counties outsource that work to, because I think they'll bring a really good flavor or perspective and stories on everything. Under the county thing too, it got me thinking, you know, local government, and I've beaten this drum a bunch in any organization I can. You know, local governments play a role. We don't always know what role we play in this, especially if we don't have a public health entity within our city or local government like some of the bigger cities do. So not just the county, but like, you know, a Minneapolis Public Health or a Bloomington Public Health or Edina or whoever has those types of entities might be good. But even I want to push us at the local government level that are smaller cities that don't have all of that should be at the table and or figuring some of this stuff out, because we're the closest to these residents and closest to these communities, and maybe have some ideas and thoughts on how we bridge some of those gaps. So League of Minnesota Cities, Metro Cities might have a place to chime in if they'd be interested as well.
Yeah, I suppose you could change county to just local government, and that would include county, city, public health association type stuff.
Jody, you had your hand up? Oh, sorry, Jen.
I just want to, I want to look at our time we're approaching the 3:55 mark. So.
Otherwise known as 2:55 for those of us.
I'm sorry, 2:55. I'm in Maryland. Need to put a Post-it note on my computer. So
Jody, if it's okay, we'll come back to you after we open up the open part of everything.
Yeah, and to put a pin in it, we will go back exactly to that section and finish up there, and be thinking about also interviews that might supplement the groups that you finalize or decide on
All right, so there it is. So at this time, take the opportunity for the public to comment. If there's anybody in attendance at Andersen that would like to provide comment. And then just a reminder for those of you that are viewing live stream, you can continue to submit comments via the email address, and then those will be shared directly with each of us. So Natasha or anybody there at Andersen want to provide any public comment?
I am not hearing that any of our guests wish to make a public comment at this point.
I already spoke, Josh, so I'll keep my remarks to myself.
All right, well, assuming then we can close the open session. Again, reminder, send in emails, submit those comments. We will analyze those, look for themes, and then get those to all the council members and get those incorporated into the action plan report as we move forward here. So I guess we can turn it back over to Rachel and Jen and go back to that activity and maybe go right back to Jody.
Yeah, Jody, you want to jump in?
Sure. I was just going to comment, I think there's a lot of perspective that can be added from the county level in terms of county case managers and behavioral health, maybe who are working alongside hospitals to facilitate discharges and find community options for people with mental health challenges. Also disability specific, or, CADDY case managers, developmental disability case managers, min choices assessors. I think can all add quite a perspective in terms of some of the challenges that come along with arranging for discharges and finding resources for people.
That kind of relates to the next slide we have, Jen, where Jody, I think were you one of the people that stayed with us and developed those questions for counties?
I was, yes.
So these are the ones I wrote down that I caught. So I just want to see if those of you who are in that meeting know if I missed anything. So we talked about what are the workload challenges that make transition plans more difficult for people experiencing acute care barriers. So this is for counties, or as Brad was suggesting, maybe larger community-based kind of groups. What are the biggest barriers to transition? How are the challenges unfolding in your region? Are there unique challenges in your region? And then are there certain populations of people who experience more barriers? So those are the ones that I caught. Jody, did I miss anything?
I think that's a great summary of what we had discussed, some of the challenges that we see in terms of trying to identify options for transition. And I think that these questions are very encompassing. We're going to get a good perspective about kind of the issues that are most common.
Does anybody have, oh, go ahead.
Say, this is Natasha. I think we want to ask some questions about their ideas for solutions, right? I think we're missing an opportunity to say what would help. It's a hard question to answer, and so I'm not sure what the group thinks, but I know that with this work, we're always challenged with balancing the short term, like, oh my God, we got to do something right now. We got to do something with how do we build a system where this is a less likely outcome for people going forward? So maybe there's sort of a two-part question, like what could we do in the next 6 months to a year that would really help? And then maybe a longer term question of what would you like to see? And, perhaps we can tie that question to like a regional approach, like in your region, what would investments or programs or things would you like to see to make a difference in the long run? Like, I just think we have to kind of get at both, because in the work I've done in this space, the conversation quickly gets muddled because of the urgency of it. And then we're trying to build a system while we're also trying to fix a problem that we don't fully understand. So I think something on the short term, long term, dividing that may not, to me, would make sense in terms of an additional question.
That's a really good addition. any of you from that have the county perspective, do you have some thoughts on any kind of specific prompts that might be related to acute care? Okay.
So when you say specific prompts, Rachel, I guess, can you expand on that?
Yeah, I'm not a county person, so I don't know,
Okay.
but I think about, I actually have an example from a hospital person who was talking to me, and she was like telling me a specific story about a person with a intellectual and developmental disability who because they were engaging in challenging behaviors, but because of the way that the system is set up, the folks did not perceive it as being something that was acute care related. It had to do more with the disability or something like that. I don't know. I just think there's certain things that our county people run into that are unique problems that I probably don't know.
And I think keeping the questions general as they're listed here, we're going to capture that information. Counties are going to have the language to answer those questions and, in a way that I guess impacts, in a way that they see the biggest issues rising to the top, especially the piece about solutions. I'm definitely in agreement with that. I think that's a great idea, Natasha. Identifying solutions, because counties definitely have thoughts about what could help.
Great.
Rachel, I think what you were referring to is baseline behavior bias.
Thank you. I was trying to come up with something for Jody. I wasn't doing a very good job, but I think Jody already got it. So I think you're right. A follow-up, like more in-depth sort of prompting around the general questions will get you what you need.
This is Sheila Grissom. I apologize. I can't, for some reason, figure out on Zoom how to raise my hand. I apologize. But we're contracted with 3 the large metro counties. We serve about 4,000 individuals in waiver case management. And I would say one of the biggest challenges is what was brought up earlier about just knowing where placement capacity is at. There have been various websites that are often out of date. Some have been discontinued that were key resources for our case managers. One through Mount Olivet, MCCP specifically, that has kind of spun off. And so I think that data is really important. It's a lot of, it's a lot of work on case managers, whether they're operated or contracted, to have to just call and email to try to find where those openings are to help support people to transition back to the community. So I think that data, that website that was discussed earlier, is a key piece when you talk about what the waiver, CADI, BI, IDD case managers can help with.
Great.
Jody, one question.
Go ahead.
No, one question that I was thinking of from our previous discussion with MHA person, I can't remember his name now, but was, can we somehow, and maybe the county would know this, for folks that are going into the acute care setting and getting stuck, where are they coming from? And is that changing while they're in the acute care setting to a different placement outside of it? So they come in and they end up in the hospital or the ED from a residential home or independent living situation. And then when they have to discharge, are they discharging to a new higher level of support services or a different setting instead of back home? So I'd be curious how many of those, how much of that is happening versus how many are coming from a group home or assisted living like setting and going back to a group home and assisted like setting, but maybe at a higher level of acuity now, and that setting can't meet their needs any longer, might be a different population, and just trying to understand some of those dynamics. So maybe this group might be able to offer some insight into what they're at least seeing anecdotally, if nothing else.
Yeah, I was going to say anecdotally, Josh. I am seeing a lot of, I think would say more on the IDD side, we're seeing a lot of group home to hospital transitions that may get stuck for various medical reasons that DSPs or whatever, they're not qualified or we don't have enough staffing to help them come home, because I also oversee our residential services. I think on the caddy side, it's a combination of people coming from either CRS group homes, customized living, or in their own homes or apartments, getting stuck. And I'm seeing both in hospitals, but also the nursing facilities, and getting stuck there and not being able to transition home because of, whether it's lack of nursing or whether it's lack of direct care staffing. I think we see a lot of both. And we do get operated and contracted case managers. The only alerts they really get, because sometimes they aren't even informed when people are admitted, unless they're on the EAS system with the state. And that's sort of a voluntary option for case managers at this point, which we do, because it helps us step in and support the person sooner. And we always say, like, discharge planning should start at admission. So we get those alerts now, right, when people are admitted or transition to a nursing facility or discharged home. But it's still, the coordination of all of that is challenging, because there's not, you would think with the technology resources we have in other areas of life, we would have a better handle on, just like having a real-time dashboard of like, this is what's open where and what might work, but it's just not there at this point.
And Natasha, would DHS have any of this information? I mean, this would be, probably somebody that's on a waiver then, if DHS were to have some of that information, versus a private pay or individual not on the waiver, or whatever. But I just, and maybe this is just a question across the board, and it's not going to be a large data set, but it'd just be so nice to understand. And this is where, if the hospitals, as they're doing our demographic stuff, I think of anytime I've had to go to the ED or take my kids there, so they're asking the slew of questions. There's got to be a way to get what that residence is prior to admission, or, walking into the ED to exiting, and where are they going to, just to understand, because I see in my brain, it's two separate, or it's multiple separate issues. It's if there's not a capacity, because we're shifting from coming out of private residences to a structured setting, licensed setting, or some other setting that may not have the capacity to support them, versus coming from a licensed setting or whatever to back to a licensed setting that's less of a capacity, but maybe it's more of a regulatory licensing thing, because we as a provider don't feel we can do that within the scope of our training and services being provided, scope of our license. But does DHS have any insight into any of that stuff?
Yeah, I'd say we have some limited data that we can absolutely share. So since about the end of November of 23, we've had a referral form that hospitals can utilize to sort of make us aware of cases that they need help with, and then we engage with counties. So from that data, we have some information about where people were before, where they're going back to. I would just, as I say often with that data set, we've had to, just because we haven't had the resources or people, kind of artificially restrict hospitals and how many referrals we can process. So I think as long as we understand the limitations of the data, which is that it's not really the statewide view because of that kind of artificial limitation, we can definitely share that. It at least gives us some information, right? On the children's side of things, there are some different groups out there kind of in the children's mental health space, to put it broadly, that are collecting some of that information. And we've been trying to pull it together and collate it. As with anything that kind of grew, any effort that sort of grew up independently of a system, they're all sort of collecting data in a slightly different way. But there are some things we might be able to draw. So I think we could certainly share that data with this committee or with this advisory council whenever it makes some sense. We can share what we've got, I think, is what I'm going to say, as long as people understand from a caveat perspective, this isn't the full data picture. That is, I don't want to derail us back to the data discussion, because I know we went through that, but we really see that as a need, both in terms of understanding the scope of the problem statewide, which I don't think we really know. And then on the second side, the data on service availability, where there are open beds, where there's capacity is important, but much harder and much more labor intensive. So I think there's some deeper dives I want to do into kind of both of those as we get further into the report. And I'll just say, like, for example, trying to maintain a database with open beds, who has an opening, who has some capacity. To bring that up, you can do it with a small group of providers maybe, but to bring it up to scale and keep it accurate so that it's actually a usable resource for case managers is very labor intensive. And I'm not saying that means we shouldn't do it. I just want people to be really wide-eyed about, because it seems like such an obvious solution, many groups have tried to stand that up and do it, but you need to have ongoing both technical support for whatever the tool is you're using, and you need to have staff that are actually calling providers and being like, is this true? Do you actually have this opening, or did that get filled last week? And so trying to figure out a smarter way maybe to do that feels like an important part of our long-term planning, or maybe there's something that regions can develop that is a little bit more sustainable in terms of the number of human resources and technology resources that goes into it.
I would just add to that, Natasha, and I'm kind of I'm hesitant to share this as both a residential provider, case management provider, and also a guardian. I'm wondering if it would have to come down to, and Josh is going to hate that I say this, as a former resident of Elko New Market, where he's on city council. But, there are certain things we have to report to our county licensors. For example, if we're requesting to close a house, if we're requesting to temporarily increase bed capacity or decrease bed capacity. I don't know, without making it a regulation for providers to say, this person's being discharged, this person's being admitted. I don't know how else we would have real-time data that then would have to go to licensing, and somehow you know what I mean? I don't know any other way to find that real-time data without making it a regulation, but I'm certainly open to other people's ideas. I see Laura has her hand up and I still can't figure out how to raise my hand, so I apologize.
Yeah, so kind of ask for, when we were talking about the child's, like the county side of the children's mental health, is there a way to break up which ones are shelter placement? Because we have two different populations that are boarding in our EDs. We have the shelter placement population where it's more for like their safety, or they don't have somewhere to go. And then we have the mental health and or behavioral health population, and the resources for those are going to look different.
So, I think the short answer to that is, yes, absolutely, we could kind of create that division, right, or whatnot within our data sets. The question becomes, I think, to Sheila's point, how do you ensure that providers broadly defined, whether it's hospital providers or community-based providers, are giving you or maintaining accurate sort of in real-time information? And I think, so I don't want to come off and say like, oh, it's impossible, we can't do it. We can do it. I think we have to be clear-eyed about the investment and the resources required to maintain it, or smarter about how to make it less administratively burdensome, right? So is it through that kind of referral process where regions, for example, maybe have established networks of providers that they can drop a line to and say, hey, has anyone got this? This type of availability. I think I think it's just to say, let's be thoughtful about what's actually possible, because I don't see that, pulling in a regulatory infrastructure requiring providers to give us this information is going to connect the right provider with the right person. And speaking kind of from the side of people that maybe have some complex behavioral health needs, or they have complex disabilities that impacts their behavior, and they need very well-trained staff in a very tailored environment to be successful. We don't actually want that person to go to anyone that's just raising their hand, be like, yeah, sure, right? Like, we know that to do this well and to help providers be successful, there has to be this sort of matching process of, does this provider have what the person needs? Is it a good fit? But that matching takes time, and it belies the speed at which hospitals, need and expect our system to operate through. So it's trying to find, I think, some type of a path through that, and figuring out how can we leverage technology to create those sort of communities of practice, or create the infrastructure to allow that communication to happen, and then capturing the data in a way that helps us see the problem down the road. So if we're, let's say, having some sort of a database or system where we're tracking referrals and we're helping people in real time try to find the right match, then we're also capturing disaggregated data that we can there share publicly about, what were the challenges to this group of people's transitions, what was effective, what wasn't, where did they come from, where are they going? I think all of that is the direction that our complex transitions team has been driving towards. But of course, we can't do it alone, and we need other people's ideas, and we need buy-in from counties and providers. And I'm hopeful that some of the recommendations that come out of this task force will help us guide our work in the future, as well as secure resources that will be, hard to come by as we move into the next legislative session. A lot of good things we need to fund in Minnesota, a lot of important things, not just this work. So how do we be really strategic about how we're going to utilize investments? But the investments, I think Brad alluded to it earlier, there are some strategic investments in terms of people power, small amounts of recurring grant funding to regions, for example, that if we had those things in our base would make an impact, especially if we gave them the right direction in terms of what to try, how to evaluate it. Regional approaches can still, funnel up to the state level in terms of those big policy decisions. You need DHS to seek a waiver amendment to change a policy or practice that they're currently having, right? So there's a way, I think, to have those things, but the problem, the challenge of this work has always been kind of the boiling the ocean effect. We start talking about it, and every problem and every pressure point in our system pops up. And that's why, in fact, these are such hard situations to solve. So I think I'm really appreciating this discussion and looking forward to what are those concrete recommendations we can get from focus groups that this council can help us make decisions about priorities. And then we drive that forward with existing resources, look for the ones that are absent, and then keep going on this kind of continuous evaluation of impact process that we're very committed to, that is a part of implementation science as well, right? It's like you implement that plan, do, study, act. I might have gotten those in the wrong order, but that's got to be a huge, no matter what, it's my hope that that's also a recommendation that's identified in the report or the action plan is, we haven't really done anything like this before. And so, I'm not here to say we're going to get it right on the first time. What we have to do with these big systems is put something in place, help people understand their roles, responsibilities, what's expected, what we need, resource it correctly, and then evaluate if we're having the impact we want. And if we're not, then we make adjustments and we keep going through that process.
Natasha, you're speaking to feedback loops that would help us to plan, and actively make changes over time. So that's a really important consideration for the recommendations. Mary, you have put some stuff in the chat. I thought do you want to share anything, or you want me to read that out?
No, I was just referring to the, acute inpatient units in general hospitals have been working on this for the last 15 years through the Minnesota Hospital Association and the development of the bed tracker. But the piece that has always been elusive has been the acuity of the patient's need. A bed is available, but all those other things you just got done talking about enter into, what acuity of care does the patient need, and can that bed provide that acuity? And that we haven't come up with a better way of being able to do that than that conversation that happens between the referring agency and the accepting agency. And, you know, that conversation is where that information is transferred and the decision is made. So, you know, the Minnesota Hospital Association has, you know, lots of information about the bed tracker and how it's worked and how it's been developed and how it's been changed over the years.
And Nicole, you mentioned something as well, that there's a link for us. Is that that's a slightly different data system, yeah?
I think that's the same one.
It is the same one? Okay, I just wanted to confirm.
I don't know for sure, but I think it is. The MinnesotaAccess.com is the website.
Rachel, I was just going to point out that Randy was trying to raise his hand and to get in and comment.
Oh, okay. Hi, Randy.
Hi, you know, you guys talking about placement in hospital and stuff. That's what happened to me. I spent 3 months in a hospital looking for a placement. Then that placement didn't work out. And then I'm back in the hospital for another 3 months. So basically all my Social Security is used up because of this. Because they have a hard time placing obese people, which my understanding is 300 to 350. They don't want to take you anything over that. And it's been a tough road for me so far, because I'm trying to transition back home, which I need the therapy to get there, because the reason I end up in the hospital, I broke my femur and hip at home, and they didn't do surgery on either one of them. And it's just been a hard road for me right now.
Sounds really hard.
I guess that. So they need to look into places that will accept obese people, you know, because the first place they put me wasn't even suitable for me. I mean, they had the equipment and everything, but the staff wasn't there. And now the place I'm in right now, they just sort of look down on you because you're that size, which they have several patients here of my size are better. But it's just hard to get the help I need. And like for rides and stuff, if I want to leave here, there's no ride company that will take me in their vehicle unless it's a medical deal.
Randy,
I guess that's all I really
your
have to
story is really important, and I think trying to capture, you know, the kinds of challenges that you've experienced is an important part of getting this report together. So I really appreciate you sharing.
Yeah.
Well, I'm just thank you for listening.
Well, it gets me back to, you know, the focus groups and the interviews too, you know. So we talked about the county, we talked maybe a little bit of the provider stuff, but really, how do we have everything here? And so kind of circling back to that, and are all the questions going to be the same, similar across the board, or whatever? And then hopefully we get to how do we actually get those groups and solicit that feedback.
Yeah. And so thanks for doing that, Josh. We really needed to kind of zero back in on the other focus groups. I see that, Laura, you have your hand up. Is it something that we can use to transition?
Possibly, because it does have to do with the other areas, but it does also tie back to that bed or placement. So whatever those resources or entities that are placement options, if we are creating a bed tracker for them, we should see if they'd be willing to report like what their capabilities are, and then set up like a tiered like acuity, where they could say, you know, if we defined what acuity means, they could say we have 1 high acuity bed, 2 low acuity beds, or whatever we determine that definition is. But then up front when they registered, it might be a little bit more of a burden, but then as going forward, it would be like more of an intuitive, and then they would have a way to like designate what their capacity is and, you know, whatever their indicators for that capacity, whether it's staffing, what have you, but maybe ask questions to our provider groups, like if they'd be willing to participate in a system such as that.
Yeah, I like the way that Jody kind of outlined the focus group questions as sort of the bigger picture, with the idea that those deeper dives that you're talking about would kind of fall under maybe bigger headers. So I think we learned a lot from those of you who kind of came up with the county questions. And I think some of those questions might be reframed and put into these different groups. That may be something that, you know, when we talked about having a smaller group working on things, that we kind of had in mind. So, you know, when we think about July, and we said we were going to think about, you know, getting all of these finalized, we're going to need to have the IRB done this month. And we're going to need to have flyers or some sort of invitation process for these different groups that go out, as you know, at the end of June into July. When we have the July meeting, we're going to need to move pretty quickly on the timeline. So one of the things that maybe we need to do is kind of really focus on the timeline for the flyers and the invitations, get the date set for these focus groups. But if we were to look at some of those questions from the county, I don't know if that's what you're doing right now, Jen.
That's what I'm doing right now. I'm trying to capture what
Yeah,
folks are
thank
saying.
you.
I
So
think there were a lot
what
of
Jen
data. Yeah.
has copied and pasted the county group questions. What we need to do is hit providers and ask the questions at that big picture level, knowing that what you're speaking to, Laura, is a deeper dive that might naturally go into one of these bigger picture questions. So it's the same kind of question maybe around provider related focus group questions.
I also think a relevant one for providers is, how do they determine their staffing levels? Like, do they hire once they have accepted a client, or do they accept clients based on what their current levels are?
Okay. And I think, you know, what are the challenges related to that is kind of what you're speaking to. Other questions?
I'm wondering about how do they access specialty training? Thinking about what Randy shared. It's, you know, and that's, you know, his needs are, you know, staff need to have the appropriate training like he mentioned, but there's other, you know, specialty training needed. And so how are they accessing that? How are they paying for that? Are they able to find that and accomplish that and retain those staff in more complex care settings?
Yeah, that's a good question. It may be that there's a question around transition for providers, like what are the challenges around transition from, you know, helping somebody transition from acute care. Like I think about Randy, what you were talking about, you know, from that provider perspective, what are they running into that's causing the barriers to getting people back into their homes?
Also, what are some environmental challenges, like as far as what Randy was referring to too? There's a lot of services or entities that tend to have a weight capacity, you know, and there could be some other environmental restrictions that keep them from.
And so this is Josh again. You know, there's been so much work done over the past couple of years with providers. I even think with hospitals, you know, everybody push back on me if you think this is stupid, but I think, you know, our focus could and should be, you know, in these particular focus groups, if we need to, you know, prioritize timing and get groups together, it's folks with lived experiences and the families associated with them. It's the case management / social workers / relocation workers that have firsthand experience of the barriers that are placed in front of the individuals they're trying to support. I think so much information has already been shared between disability providers, maybe older adult providers with DHS that we probably have those notes captured somewhere. If not, it won't take long for those groups to regurgitate and talk about all the issues that you know, we know exist. Hospital, same thing. Lots of information has been put out there from their perspective. But really, if we prioritize like the families and individuals with lived experiences, I think would be the biggest impact, or the voice maybe that hasn't heard the loudest yet. And that's older adults, folks with disabilities, parents of kiddos, and that whole continuum of individuals, and then maybe some of those supporting complementary folks that are doing the hard work in the trenches right next to those folks with lived experiences, would be my perspective or feedback or whatever.
And I wanted to make sure we caught the earlier interview suggestion, which is somebody from Carroll's area around Center for Health Equity, or whatever what it was called now, the division. That would be in the interview page. I think that would, I mean, Carol, do you think that's where we were headed with that?
I hope so. Like I said, I just feel like I have to kind of measure a little bit of bandwidth at this point before I commit folks, but I'm happy to explore that.
Yeah, it's an invitation. It's not necessarily, you know, a done
Yeah,
deal.
thank you. I appreciate that.
Yeah, I mean, I totally get that we have to explore these. These are brainstorming ideas, so. Great. All right, so we've got to start on some of the other sections. We certainly don't have to get it all done today. I know we're heading towards moving towards the last section, which is sort of a way of thinking about getting ready for the next meeting. It might be, instead of trying to wordsmith when we're getting tired, just getting a plan to get these focus group questions organized and back to you in a way that makes sense. We've talked about July being a point where we would have these done. I would hope that they'd be done and finalized before we could, so that we could move forward with the focus group and interviews during that month. So that's kind of my thought on getting this part done.
Laura, you had your hand raised?
Thanks, Danny.
I'm just wondering, for the families and people with lived experience, that focus group, do we have a method for identifying and reaching out to them? Because the way I found this group was a little convoluted, and so I don't know if others would know to access or
could potentially use our case management contacts, right? So they're county affiliated, whether they're contracted or operated. I mean, those are, and I can speak a little bit to rural and metro, because my sister, who I'm guardian of, who's been stuck in hospitals before, is from the rural part, and then we do case management and residential in the metro. But those case managers could probably point us to people who have had lived experiences being stuck. And again, I agree, there's more data out there on the pediatric population than the adult population. And so I think we would probably need that, if not from the hospital social workers.
Yeah, that's a really good point. I think we need to think about flyers that speak to different people with lived experience. So we've heard about, younger kids that are getting stuck. We've heard about older adults who are having challenges. Randy's just given us an example. So trying to come up with a way to send flyers out through the county would be a really great idea. And if we could kind of use the existing listservs and processes that we already have.
Exactly.
And a flyer out so that people can, if they're interested, can kind of reach out to us.
And I think it could almost be a dual purpose notification, right? We're looking for county, but we also want to know, like, because it is not, you know, case managers are not in this work to not support people getting back to the community, right? Like they want to be part of the solution. And I think they could also point us to people who have been stuck or family members of those who've been stuck or you know, struggling with that transition.
Yeah, good point. Okay, so it sounds like we are moving towards just a basic system for, you know, in the backward plan, we have University of Minnesota IRB. In that IRB, we create the flyers. What we might do for a flyer is have something that is kind of driven by listers that DHSU have already that we can send out, but then the flyer itself might have like, have you experienced challenges with regards to transition and in these areas, and kind of bullet out the different types of people that might have had that experience, so that if somebody reads it, they go, oh yeah, that's me, or that's my son, or it gives them a chance to kind of understand what we're seeking.
It'd be interesting to get this information out to the regional AAAs and senior linkage line folks and or disability hub folks to see if they, you know, hear this or if they have stories or connections or whatever, but just to loop them or those types of groups into it who are navigation-like centers and take phone calls. And, you know, I think of ombudsman's offices and regional ombudsmen as well that might have some insight or connections into these types of stories.
All right, so in the chat, if you are interested in this area, so we've talked about earlier, we talked about the action plan report. Now we're going to talk about just driving this through starting this month and moving into July. We're going to get this all together. If you're interested in helping us to make sure we get those flyers right, give us ideas for, you know, where we should send this out through, go ahead and put it in a chat that you're interested, and we'll keep you in the loop as we kind of get these materials together. Thank you, Sheila. Appreciate it. I think that this is a important area. I know it's going to move pretty quick, but I think that having that partner experience is going to be really important. Jessica, thank you for joining as well. And it should be pretty low effort. I mean, the university will drive this and getting everything ready to go. So hopefully you'll be just responding to stuff and saying, have you thought about this or that? So great. Thank you. Okay. We are right at the last section of the meeting, which is kind of like, I mean, we've done this each time, which is we've reviewed. Jen has helped us kind of think about what we said we were going to do to make sure we've got it all listed for the meeting minutes. And I don't know, Jen, do you want to jump in? And I know you went through the actions earlier. Did you get more actions for us, or?
Well, the last action was, most recent action was around the ICI staff developing flyers that appeal to multiple audiences and working and sharing those with the council.
Yeah, I know. Now we gotta back up in our minds. Like, I don't want you to have to report what you already did for actions. It's just if you've missed anything. I think you know, the last time you reported out an action was for us to get something for Carol that was like a summary that she could share. I think that was the last one we developed. So if you have anything in your notes, believe it's mainly what you're talking about, which is, you know, we will be just as a review gearing up for a July meeting. Jen's going to send those out. We already know July is really tough for people. That's why we made that assumption that there may not be a quorum. July is just not a great time of month to have a meeting. So if you can make it, that would be wonderful. We really do have important things to share. So we do have the MHA and MDH presentations. And Carol, I remember hearing something about maybe we need a meeting or a preparation sort of process or something to kind of connect with your people so that they can ask questions.
Yeah, and I want to just make sure I understand like the MHA piece of this too, because we worked with Wilder on this study, and so I just want to make sure we're all on the same page before we present the data to this group. That's all.
Yeah. So so you're suggesting a meeting with MHA as well?
Well, I don't know. See, I didn't like in our internal briefing, MHA wasn't a part of the briefing. So that's why it was news to me to see MHA on the agenda too. So
yeah, so just as I mean, you might see it in the meeting minutes. We what we talked about was MHA had some data to share. You guys have data to share. I know that there's some linkages between how you guys are doing things and MHA. So we thought of when we wrote down the motions, we thought they were separate things for like 20-minute presentations that each of you would do.
Got it. Okay. So it's not tied together correctly.
Yeah, so sorry for any confusion. That's on our part. We just wrote down the motions and kind of proceeded forward. So yeah, thank you. So 20 minutes, in particular, the MDH study, we just need, and if you want me to write something for that too, I could certainly do that. I know sometimes being the carrier of information is challenging.
No, I'm fine with that. It just, if it would be helpful, and maybe we don't need a prep meeting. I was just thinking that there was going to be a little bit more sort of conversation before we brought it to the committee. But if our team feels prepared, then we can certainly be on the agenda for the 14th. We can be on the agenda no matter what. The question will be whether or not our team still feels like a prep meeting would be helpful. Thank you for understanding and thank you for your patience.
No, I apologize for anything that got confusing. My understanding is that study is just wrapping up or has just wrapped up. Is that correct?
That is correct, but we don't have like a rollout plan or anything like that yesterday. So yet. And so this would be our sort of first like kind of external glimpse at this. We have had the internal briefing, but I just think we want to make sure all of our ducks are in a row before we talk about it more externally.
Yeah. And if you do need more time, let us know, because there is the August meeting too.
So we will have a July meeting. Is that what you're saying? We don't have a date yet.
We don't have a date yet. What is going to happen is Jen's going to send out a doodle. We did try to get a July date just as a historical piece, and we found that it was really hard to get everybody together. But given that, as Brad has pointed out, we need to be moving forward pretty quickly. We thought this would be a solution that we could move towards, is to have this July meeting, and it gives us that time to work on the action planning items and all that kind of stuff. So what we're proposing for the next meeting is that we have MDH and MHA present for 20 minutes each. So you each have separate, like this is what we did. This is the data. And then we would actually use the rest of the meeting to zero in on the focus group interview sort of process and where it's at. And we would focus on the recommendations and really kind of get this report to the next stage in the way that Brad kind of pointed out. We need to kind of keep hitting some benchmarks.
Yeah.
So yeah, that's kind of what I think July is looking like.
Okay. Thank you.
But I do, Carol, I want you to know, if you all feel like, we just finished this dang study, like I think isn't it Jen, August is the next one?
It is in August.
So Carol, you have the option to bring that to folks if you're feeling rushed. You don't have to feel rushed. We could squeeze it in and just do adjustments to the report based on what we learn.
My sense is that July will be just fine if there is a meeting.
Perfect. Sometimes it's good to keep you moving forward on the
exactly. I'm with you.
Thank you. Okay, perfect.
So Rachel, I think that brings back to action items. Some are definitely for the ICI staff. So for instance, I'll send out some polls to identify a date for July. that when you asked about the flyer for Carol Backstrom, I want to make sure that it is reflected in the notes accurately. Is that similar to the flyers for focus groups, or
So
how are those different, or how are those
yeah,
the same?
Carol asked for something. So we had been talking about the Center for Health Equity and whether that would be a group that we'd want to kind of dig into. What do they have? What kind of things are they considering challenging for statewide reporting? You know, so that was where it started, right? Carol's having a little blurb that it's not so much a flyer, but a blurb that would allow for us to take that to, Carol could take that to cover. So that's one piece, but I was asking Carol if it would be helpful for her to have something for the presentation on July. You know, because that is my thought, is maybe that's could be helpful. I don't know, Carol, maybe
I'm
not.
clearly making things more tough for you because multiple asks. I think my takeaway from having the conversation about the health equity division is whether I think it would be helpful for them to be aware of the kind of outreach that we might be doing, and they might have some ideas around not only data sources, but groups to be talking to. And then if that's the case, the other thought I had is there's someone from the health equity division who would be interested in participating in these kinds of facilitated conversations as part of their work, if they have an interest in this area. And then the second part, it sounded like, Rachel, is really around sort of asking some questions around MDH data, like where do we have more sort of disaggregation or health, race and ethnicity data around sort of our different data sources. I don't know, am I kind of remembering that correctly?
Yeah, that's helpful. I missed that little chunk.
Oh, well, I'm hoping that's what I heard. Sometimes.
Yeah, no, that's good. I think that works really well.
Then the second part was just around sort of do we need a prep meeting for July? And I think the answer is going to be no, but it would be great to be in touch, so I can be in touch with our staff about the potential date, and then making sure that they are ready.
So, Jen, we should put down that we'll check in with Carol and just make sure that we know, what's needed. Okay, perfect. We're heading towards 15 minutes. I know you hanging in there. So I was sharing with others that 3 hours is a long time for using your brains. I feel like I'm smoking a little bit out the edges. But we really appreciate your time on this, and I feel like we're making good progress. So Jen, is there anything else we need to zero in on in the notes?
I don't think so. I mean, I have the ones from earlier where we'll share a working draft of the literature review.
Yep.
The other thing that I had as an action, but I don't know if it's embedded within the focus group work, is Sheila's suggestion of how we identify families and people to include in those interviews and focus groups of contacting case managers. So I think an action there would be for the ICI staff to connect with council members to identify how to identify people for these focus groups and interviews. That needs to be done after the IRB is completed.
Yeah, and part of that is linked, I think, Mary, tell me if this is right, to the conversation about the flyers and sending it out through the counties, right? So the counties will know people who they could share flyer anonymously, and if they're interested, they could sign up.
So those are all the actions I have.
That's the one area that might bump us from an exempt IRB. Exempt IRBs are usually for things that are like public interviews and things like that. But when we're doing interviews with people with lived experience, sometimes we need more around consent, assent, that kind of process gets a little bit more involved. So
the only other action item that I have, not for ICI folks, but is for the rest of us, once we get that lit review information and or any time in between, sending in the recommendations to ICI staff of, putting in writing some of the recommendations we have so that we can start sending that to you guys. Yes, we, had a really good discussion today, but anything in addition to that or to reinforce that, start sending it your guys' ways. You can start compiling that and using that for draft of the report moving forward. So just re-emphasizing that again.
Thanks, Josh. Okay. All right. I don't think we did, the only motions we did were agenda and, did we do we didn't do any motions, did we today?
Agenda and meeting.
We did, okay.
Mhm.
That went pretty fast. Okay, well, we're at about 10 minutes till. I think we could probably end the meeting or a little bit early, given that we've gotten a lot done. Your thoughts, everyone?
Sounds good to me. One last plug thrown over to Natasha before I close it. I think over the next couple of months, and my brain's already on 2025 legislative session, is, as the department is getting back into the groove of developing priorities and stuff, if there's any related or potentially related priorities that may be coming down the pike for this kind of work, to have those ready to discuss and or throw out, because I think anything that we can reinforce potentially, not necessarily be driven in that direction or whatever, but anything that we can reinforce or at least not conflict with, or at least be aware of. I think it was super helpful to have Christy here in the fall, kind of going over the overview of what DHS and the Gov's priorities were, and then we can see if there's any syncs in that or some overlaps, and however we can support those efforts, knowing that time frame will be upon us very quickly here.
Yeah, absolutely. And I would just say, I think the timing again of the submission to the legislature is intentional so that we can, at the department, as we're developing proposals and priorities, use the recommendations of the report to kind of, provide the rationale for why we might be moving forward with certain things. So we definitely will be taking that into consideration. I mean, obviously I have to say all the same caveats of we don't know how much money there's going to be or what the governor's budget for 25 is going to look like, but certainly the purpose of advisory councils like this is to provide that structured way of getting input from a variety of stakeholders so that we're on a more solid base when we come forward with ideas at the department, or so that, other folks or other people that bring legislative proposals can also reach out to their legislators and, we can give technical assistance. So I think, it's the timing works out well for 25. It's a little bit later in the day for DHS's internal processes, but there's ways that we can work around and through that because, again, the legislature knows, and I think that timing was intentional. So I think for that flag, we can also at a subsequent meeting or in July, if we have time, talk about what passed in the previous session related to acute care transitions. That can be super quick, but that might be of interest to the group as well.
Any other comments, questions, or anything for the group? Seeing and hearing none, the meeting can be called adjourned. So thank you everybody for your time today. Appreciate it.
Thank you.